Good afternoon, ladies and gentlemen. Thank you all for coming here today. We'd like to welcome you all to the Northeast Pandas Parent Association Question and Answer event. My name is Lisa Grisolia, and I'm one of the founding members of our organization. And I'd like to acknowledge the rest of our members, if they could all maybe come up. I'm sure they love me right now. I'd like to introduce, starting with my right, Jennifer Patelli, Kim Panton, Laurie Tedeschi, Lisa Hart, Peggy Chapman, and Tiffany Maxwell. Also not here is Megan Greenstein and Kathy Whitcoast. They do so much for our foundation also. Thank you. We would all like to thank you for being here today. The response to our first ever conference this past November, I'm sure I've seen many familiar faces. I'm sure that some of you were here, or not here, but in Rhode Island with us. It was so overwhelming. We had 400 attendees from over 20 states, the United Kingdom and Canada. We had an outpouring of support for our group, and we really felt it necessary to continue to bring forums like this to the public as well as clinicians. We would like to thank our sponsors also today. Without them, we would not be able to share this information with you. Thank you to Cortigen, CORAM, Molecular Labs, and also to the Pandas Network. We also have a special thank you going out to Adam McCune for filming this event. Thank you, Adam, in the back. We are all very appreciative of our speakers who have donated their time to share the information with us today. I would like to take the time to introduce them. Some of them may not be here yet, but they'll be here for the question and answer. If you are here, if you could just raise your hand, that would be great. Dr. Susan Sweeto, Chief Pediatric and Developmental Neuroscience Branch at the National Institute for Mental Health. Dr. Madeline Cunningham, Co-founder and Chief Scientific Officer at Molecular Labs. Dr. Beth Latimer, Pediatric, Adolescent, and Adult Neurologist. And Dr. Nancy O'Hara, Pediatrician, Center for Integrative Health. And last but not least, Dr. Mark Pasternak, Unit Chief Pediatric Infectious Disease at Mass General Hospital. Thank you all for being here. So whether you're a parent or a child with PANS or PANDAS, or an educator or a clinician that's supporting our children, we're hopeful that through the information that you receive or share today, we will raise awareness and expand the medical care that's available. There will be index cards. I'm sure that you all received them at the registration desk. If you don't, there's some extras around. And we'll be coming around to collect them for the question and answer portion. Please keep the questions brief and do not include any personal information on them. We would like everybody, if they could please turn their phones to silent. Once again, thank you for being here. I'd like to now introduce Peggy Chapman, clinical nurse specialist, board certified in child and adolescent psychiatric nursing, and one of the founding members of our group. Thank you, Peggy. Peggy will be giving an overview in PANDAS.
Again, thank you for all coming out on this unfortunately gorgeous afternoon. Does this go any higher? Okay, good, thanks. I'm not going to give you great details about PANDAS PANS because most of you know it, and we have the true experts here, including the founding identifier of PANDAS, which is Dr. Susan Sweeto, and she'll be talking, I'm sure, about her information more. But just to remind you that in 1998, Dr. Sweeto identified a cohort of children who presented with obsessive-compulsive symptoms secondary to a streptococcal infection. And I believe, Susan, if I'm right, it was a mother who asked you to explore it originally, by the way, not scientists like myself. It was a mother who said something strange is going on here. And she identified, because of her interest also in strep and Sydenham's chorea, which is the Luba Disorder a lot of you know about, that there was a distinct group of children who, when exposed to strep, developed a sudden onset of pediatric acute onset neuropsychiatric symptoms, i.e. PANDAS. And myself and many others over the years appreciated that because we had come across these cases, and I remember distinctly reading your first article and saying, there's one, when they came in my office. And we treated usually with antibiotics, and we often got very good responses, although all the children we were seeing were usually cohorts of other mental health issues, and in those days particularly I was working with autism, so I saw children with autism who then would suddenly present with a really large exaggeration of symptoms and treat them. At the same time, let me remind you, we were also treating them with traditional psychiatric medications and still do. Then as many of us were seeing these patients over the years, people would come into our office asking, is this pandas, is this pandas? And although the identification of strep was not clear a lot of the times, the throat culture would be negative. We didn't necessarily look in those days, I didn't, for antibodies to strep. There would be a history often 3 months prior, to having some kind of infection, some kind of illness event. Somebody had a bad head cold, stayed home from school for a couple days, and then 2 to 3 months out, they may have this sudden onset. Now, that didn't fit the original definition, sudden onset. It still doesn't quite, because it's now called pediatric acute onset. But in fact, since the titers peak 4 to 8 weeks from the event of strep, sometimes the occurrence of the behaviors will peak as the titers are peaking, not 24 to 48 hours after a strep infection has been identified. And also, as been noted in the literature, strep swabbing is often it just doesn't work. You almost have to make them throw up to have an accurate swab. So with that effort and many other physicians who got together in 2010, there was an attempt to broaden the definition based on a lot of clinical experience. I believe it was over 400 people they were representing, who seemed to also have kind of pandas presentations. But they also had noticed a very large subset of other symptoms that were starting to be able to be identified and emerging. So out of that group, they re-identified what they call PANS, P-A-N-S, Pediatric Acute Onset Neuropsychiatric Syndrome. There's also CANS, Children Neuropsychiatric Acute Onset Neuropsychiatric Syndrome. But that was somewhat dismissed by some people because it limited the definition to the original, which is up through 12. And a number of us had started to see patients who were in their adolescence. I saw a child who was 16 when I met her, major social anxiety, learning disorders, and about 17 and a half, she came into my office for a regular visit and started leaping out of her chair, literally. Her body would just take off like a foot. And I said, what are you doing? She said, I don't know. And it got so bad that she couldn't walk. She couldn't walk straight without falling over. She had to wear a helmet. Her mother had to walk near her side. And I began to think, is this a brain tumor or something? But I also said to myself, maybe this is pandas, because I'd seen it in some other adolescents. And yes, in fact, she had acute onset symptoms, and she had a positive strep culture, not a culture, but a positive strep antibodies. And with treatment, again, both traditional and antibiotics, she got better, but it was a long time. She was clearly quite inflamed in her brain. Her body would leap as she was walking. She would hop and fall. So with this new definition, which is an important article if you haven't read it, particularly those who might be new to pandas and PANS, it's 2012 February. If you go to the NIH website, it's there. And it importantly identifies, again, OCD. And tics is not listed in the big boxes, but certainly tic disorder presentations is part of this group illness. But tics present a different conundrum of diagnosis. Tourette disorder emerges frequently between the ages of 7 and 8 to 12. So there's a lot of psychiatric differentiation that has to go on, because you could just be seeing a child who was sick and a child who's presenting increasingly as a patient with Tourette. So, but just to remind you that OCD is still the major presentation, but you really have to work hard sometimes. Sometimes what appears to be severe separation anxiety is in fact OCD, and it's an obsession, for example, that they'll die if they leave home, or if they leave home, somebody else will die. That's an obsessional thought, but it comes out as severe separation. They can't go to school all of a sudden. So again, sometimes we think of traditional OCD, we have an action and then we wash our hands. That doesn't always take place in any OCD. But again, sometimes what appears to be separation anxiety is in fact based on an obsessive, in unremitting obsessive thinking. So just to remind you that in addition to OCD, and then tics can also be occurring, we have two of the following: severe anxiety, emotional lability, and mood. So all of a sudden they're asking me if all of a sudden are they bipolar? Irritability, regression, and severe oppositional defiant disorders. And often the defiance is not your typical oppositional defiant disorder, the child who breaks neighbors' mailboxes or tears your house up on a tantrum. They're usually oppositional to you're wanting them to do something that they're incapable of doing because of the way their mind is dictating the rules of life at that point. Developmental regression. A lot of parents will tell me how they start baby talking, sitting on their laps, thumb sucking, all these things I haven't seen for years. Deterioration in school performance. If you haven't seen the article, again, it's precious in describing in detail a picture of a microscope, beautifully labeled, in the same child's work after PANDAS, where you can't make out a name. And I have seen this repeatedly, where you'll see a piece of work and then people are complaining that they're sloppy, that they're handwriting, they're just not trying. Children will start to refuse to do their homework, and you have to be wondering, is it because they actually can't write? Or they have you write it out? So be looking for that. Sensory or motor abnormalities. All of a sudden, they can't put on their clothes, they can't eat, they're restrictive about what they drink, their sense of smell is extremely acute, many of them. And there's a cohort that was identified by the study group of serious onsets of eating disorder, anorexia nervosa, because this intense restriction all of a sudden to eating. And there are sometimes kids who have accompanying excuses that they don't want to be fat. But again, sometimes it's really hard to differentiate, and I've had a number of calls over the last 2 or 3 years of parents who have realized that perhaps their anorexic, now 14 or 15-year-old daughter actually had PANDAS at age 8 or 9 when they started the journey, and they've been living in hospitals for a long time, in and out. So hopefully, as we educate, another group that really has to be educated is the group that's evaluating eating disorders because of this presentation. Somatic signs, including sleep disruptions. Somatic is physical, so these are kids who have normal sleep patterns. All of a sudden, they need to be in your bed to sleep. They can't go to sleep without you being in the room. They have night terrors. They wake up with nightmares. They start having urinary urgency in the middle of the night. They wet their bed. They dribble urine in their panties in their math class. They are petrified that they're going to wet themselves. They trip over their Xbox wires to get to the bathroom when normally you couldn't disrupt them from an Xbox if you paid them. And again, you have to be reminded it's a change of behavior. It's not just a behavior. And last is that nothing can further explain these things better than PANDAS. Now, that in itself, for a clinician, is a huge conundrum. I can probably pretty much explain everything I just discussed away from my traditional psychiatric training. Are we having separation anxiety because of some issue at home, issue with the marriage, issue at school bullying? Are we having a urinary tract infection? Are we having anorexia? So it's a lot of science that still has to evolve, a lot of definition. A lot of your stories educate people like me because you may not fit the box. And as you know, as you talk to other parents, as you discover this for yourselves, that maybe PANDAS is involved in your child's state, it doesn't fit frequently the description of immediate to the streptococcal or viral infection. The other thing is we are seeing increasingly in pockets Mycoplasma pneumonia as a stimulus. I have a child recently who it's clear it's herpes. His behaviors were all PANDAS related, and the stimulus is when he has herpes breakouts. There are kids who have been registered who have had mono. They're viral infections, and there's a lot of viruses going around. This year, in fact, in this area, it seems to be more viruses to me than even strep that's keeping people home and sick a lot. So the final piece to remind us all is that this science is evolving. Hopefully this conference and this weekend will help the science evolve. It helps us think about what questions have to be answered. Science, I hear from a lot of you, is too slow for you. It's very tedious. It's very problematic that things don't get published right away. Studies have to be completed. So I appreciate, because I hear it all the time, of your frustrations about how we're not moving fast enough for your lives. So you have to keep representing yourselves and your children. We have to keep representing the science. As you remember and know, many of us are, I heard the other day that I was considered just a nurse, therefore I shouldn't be diagnosing pandas. That was from a physician passed on to me. There's a lot of pushback, I will have to say, on behalf of myself and other physicians and medical people here. There's tremendous pushback against us, that we're crazy, that we're risky, that we're doing these horrible antibiotic therapies. Wouldn't I please rather put the child on risperidone or Zyprexa or Haldol? No, I wouldn't. But that's the pushback I get all the time from my colleagues and your pediatricians. So, you know, with patience and with love, we're working our way through this, but just remember that it's a twofold process. It's your stories and your treatment and the science that's trying to keep up and trying to match your needs. There are also times where I'm going to say to you, your child has OCD separate from OCD pandas. In other words, there are children I see who have pre-existing social anxiety disorders, they have pre-existing OCD, and we don't know where the line divides. Some of you might be convinced that your child became an OCD person at age 4 suddenly. I'm not meeting them until they're 10. There's a whole lifeline of OCD going on and developing, which in and of itself has biological implications in the brain. I also haven't touched on, because a lot of other people do it, the whole immune modulation process that's going on behind this disorder. Again, something that's being discovered, explored, tested. But as an overview again, the way we're treating it is a combination of antibiotics and traditional medications. And as many of you are now moving into, kind of what are the supplementary immune supports that could possibly benefit our children as well along the way. Thank you. And I just am going to now introduce Heather Troyaner and Susan Condick of CORAM, who are going to talk about IVIG, a thing that I have a lot of questions have been answered, and I'm looking forward to this. And thank you all for coming again.
Thank you for having us here. We just wanted to introduce ourselves. My name is Heather Troyaner, and this is Susan Condick, and we both work for CORAM. We just want to tell you a little bit about what CORAM is, and what we do. So CORAM is a national infusion provider, and we do home infusions, many different therapies, but one of them being IVIG. And some of our key messages that we want to talk about is patient safety is first and foremost what CORAM is all about. We will do a full assessment by nursing and by pharmacy before we actually will infuse, and we speak directly with the physicians. We have product access. We are one of the biggest providers of IVIG. Can you hear me? Okay, sorry. Sorry. We're one of the biggest providers because of our national coverage, so we have all of the different products available to us. And currently there are no national shortages, but even in times of national shortage, CORAM is most likely able to get the specific product that you may need. Convenience is one of the biggest things. When you do this in the home, we can really customize the time of the infusion. So if your child's trying to go to school, we can make accommodations to do like an evening visit or a weekend, which really does help keep, a normal lifestyle. And one of the things we wanted to talk about is our local presence. We're from the Norwood office here in Massachusetts, but we have over 80 different pharmacies across the country. And I do have a slide with our map that I think we can just advance it to the next one to just show you how big we really are. And we were recently purchased by CVS Caremark, so now I think you'll see us expanding. One of the things we wanted to talk about is how to make a referral to CORAM. And it's fairly simple. If your physician wants to ask questions or prescribe, they can call us directly. They can speak directly with a pharmacist. or we do have some referral forms they can fax in information. We do have a dedicated national call center who their job is primarily to get the insurance providers to cover this therapy, which we know can be very difficult. But we will work directly with the insurance company. We will help the process through appeals with the doctors. Sometimes they can get on the phone with the insurance company. So we can really handhold through the process. Once a referral comes in, you will actually speak directly to one of our nurses, and actually that's Susan's position. And we can send out information about the different products, et cetera, et cetera. And once the patient's on service with CORAM, our pharmacists do complete assessments. So between the nurse that's coming into the home and our pharmacist, we're always assessing if there's any reactions and how do we treat and work through that. And that's ongoing once the patient's onboarded. And then I did want to speak a little bit about what CORAM does nationally. We do have an ideal registry, which for the physicians is a great source. So a physician can actually enter the patient information into our registry, because our goal is really to take all of the information that we're gathering and present it back to the insurance companies to hopefully get this to be more known and to get better coverage for this therapy. So that's pretty much the overview of what CORAM is. I didn't know if there was any questions that anyone had or wanted to ask.
What was the telephone number called? You said call the referral with the number?
Yeah, I actually have some business cards, but you could call us directly. Are you in Massachusetts?
Yes.
Okay, so you could call our 1-800 number, which is 1-800-678.
3442, and they can ask for me.
And they can ask directly for Susan. She's in the office.
Also, if anyone has any questions, they can come down to this microphone right here.
Do you mind talking a little bit about the different products?
Oh, sure.
Thanks.
Yeah, I actually had, and I think I gave the last one away, but we have every product available. And we actually have a little handout, and if you guys would, if anyone's interested, I can send you those. I do have more coming in, but it goes through all the clinical differences between the different products. So I know that the Gamunex is a very popular IG, and there's also GammaGuard. Those are probably our two top prescribed infusions.
No parents are often like, which one should I do? Is there a difference between them? Do you have any insight to that?
It's really patient specific. So we would work directly on, looking at each patient if they had an allergy or if they had ever had the therapy before. We always try to stay with the same product, just because there are slight differences. Some are dextrose. I mean, you might know a little bit more about some of the basis, but basically, those are the two most prescribed. And then I don't know about, I've seen all different types of dosing, so that was another thing that we would look at. Some are doing 1 gram per kilogram, some are doing 2 grams per kilogram, but that's definitely physician specific.
Hi, can you say a little bit about the diagnosis codes that you're using to get approved and, at codes?
Exactly. That also is patient specific. We will look at the clinical information and the lab work on each patient. So there is no FDA approved PANDAS ICD-9 code at this time. So sometimes it's autoimmune. The other one that sometimes is encephalitis is another diagnosis code that we've seen. But it would really be, you'd have to look, the clinical information on each patient is really what the insurance company is looking at. So it's not so much a code, it's more of the history, the lab work. So it is an autoimmune, so sometimes the IG levels can help play a part in getting that approved.
What is your success rate amongst the insurance companies in paying? Are there any insurance companies that just will not pay?
There are some that won't, and they have it in their exclusion criteria. So, I mean, it's really hard to say because I can't even put a rhyme or reason to why they will approve and why they won't. But if we can get the supporting clinical documentation, sometimes that does help. And appeals have been successful sometimes, depending on the insurance provider. And healthcare is changing so quickly that it's hard to really, know if
every year it seems like an insurance company can take things out or add things in, so we're keeping up with it as much as we can. But that's what our national call center, that's their job, is to go and, present to the insurance companies to get it approved. So they'll stay on it and make the calls, and they do all that for us.
I was wondering, you had mentioned if insurance doesn't cover it, you can self-pay?
Yes, sometimes that's the last resort, is that if you do really want to proceed with the therapy and you've exhausted the insurance, self-pay is an option. And we can do payment plans as well, so.
How much typically is one infusion?
It's product-based, and it's interesting because I learned so much just working at this job, but IG really is like, it's almost like a market, it changes a little bit.
The pricing per
Pricing,
grams.
yeah.
So it's based on the number of grams, so it's hard to give a blanket price.
But it's typically in like thousands.
Yes.
Yeah, at high dosing, yeah, it can be. And it's weight-based, so, depending on the weight of the child.
Did you touch on the difference in cost between institution?
In home?
Yes.
It's interesting because, I didn't really, know much about this until I started working in this job, but actually was able to compare out of one of the big hospitals in Boston. I took the same grams, and it was I forget how many grams, like 30 grams, I think, and that child received a bill, and it was over $15,000 to have it done at the hospital setting because of all the overhead and everything. And we compared the price, and it was about $5,000 to $6,000 to do it at home. So there is a significant difference between a hospital setting. And one of the things CORAM does have is the infusion centers. We don't have one currently in Massachusetts, but we do have two local, Connecticut and Maine, and they're about an hour and a half from Boston, each center. So if, home is not something that people are comfortable with, we can help support that. We're hopefully getting an infusion center soon with our CVS Caremark counterpart, so I'll keep Kim up to date on that.
Can you talk a little bit about what the nurse does when they go into the home?
Sure, I can talk about that. Sure. So the first call that generally comes into the office when I speak to the parents, I do a complete assessment to determine allergy history, and just to make sure that it really is safe to do it in the home, because we would never place a patient at risk. And then when the nurse arrives at the home, so all the medication is delivered from our local branch in Norwood, and the supplies and the pumps that we use. And the nurse comes into the home, she'll start the peripheral IV. Generally, most patients are done peripherally, and then prepare the medication and then administer it. We do follow manufacturer guidelines, and then we also follow whatever the physician wants. Some physicians write for less milliliters per hour than what the manufacturer recommends, just because of side effects. We do try to determine side effect management up front, because it is high dose. It is common for these kids to develop, headaches, nausea. So we try to manage that before it happens. Yes.
Going along with that, the one that scares us to death is anaphylaxis. How do you handle that in the home?
Yes. So we provide anaphylactic medications. We have diphenhydramine IV, and then epinephrine. Most of these kids do pre-medicate, and we start the medication at a very slow rate, so that if a reaction would occur, there would be less drug on board to counteract giving the medications, the diphenhydramine and the epinephrine.
And if you see that they're having an anaphylactic reaction, are they then transferred to a hospital, or do you continue to manage them at home?
And if it was a true anaphylactic reaction, no, we would start treatment and call 911. That's why a parent or adult always has to be present during the administration process. I've been doing home infusion since 1984, and I think I've seen one true anaphylactic reaction to IVIG at home.
We've had one in hospital, so it's not common, but if it happens,
Yes, it's not common.
everybody is terrified.
Yes. Yes, yes.
I will mention that my daughter has had IVIG in an infusion, inpatient at MGH, and now she does get it through CORAM at home. And the nurses that come are fantastic, and they will also, educate whoever's staying with the child how to use the EpiPen, what signs to look for, and I feel really comfortable with that.
Mhm.
Let's see, a question there.
It could be anywhere from 3 hours to 18 hours. So it generally, I would say 5 to 6 to 8 hours. We do very conservative infusion rates in these kids at home.
Plus some of the prehydration too takes, you know.
Prehydration, IV hydrocortisone, or depends. Every child is different, the way, what they're prescribed. Yes.
Hi, my daughter had IVIG last summer, and we're considering doing it again this coming summer. I'm wondering, well, 2 questions. First is, if she tolerated it well the first time, obviously no anaphylactic reaction or anything like that, does that mean that basically we've got nothing to worry about the second time, or is it?
No, I mean, IVIG is a blood product, so you can react anytime,
Okay.
Whether it's the first infusion or the 10th infusion.
Okay, so that's not an indicator of,
No, generally not.
okay.
But that goes back to speak about the products. That's why we like to maintain consistency with the product that the patient has received previously, because then there's not a significant change in the formulations.
Great. And my second question is for kids who have it more than once, what's your experience with insurance? I mean, will they pay for it the first time but never again, or will they?
No, we've seen them pay for it more than once. Yes.
All right, thanks.
Mhm.
Sometimes our authorization is for a certain amount of time, depending on the provider and what the doctor has prescribed. So if we know that you're gonna need so many, infusions, we'll ask for that up front.
That way, each time you need an infusion, you don't have to submit for reauthorization.
Okay.
I'm so grateful you're here because you're answering all the questions I've been saving up.
Oh, great.
We have been following the literature in pediatric journals on the faltering effectiveness of IVIG for Kawasaki's, for ITP, and for other very classic autoimmune diseases. Have you, especially since you've been doing this since the 80s, has that been your experience, that it seems to be working less well than it had in the past?
I don't personally have any experience with that to speak of. I don't know that I would see that in the home infusion end, or maybe more in the hospital, because oftentimes patients with those disease states will be dosed initially in the hospital and then come to us. But I do have to say, I see that particularly the ITP patients seem to need it more frequently.
Yeah, I think that's what they're speaking of.
Yes.
He used to be able to cure Kawasaki's with a single dose, and now they're doing sort of multiple dose infusions similarly for.
Yes, yes. For the ITP, I have seen patients, and so I thought, is it related to the disease process that they're more sick? But yeah, I have seen that.
And that's one of the things with the ideal, is that we can gather that data nationally. If you have a researcher or something, you can access it. So.
Do you have well, we can talk about that
Yeah.
offline to get a contact to your
Yeah.
physician also.
Are there any more questions, though?
My daughter hasn't had to have that yet, but I'm from Ohio now. Where are you? I see that you're in Ohio. Where?
We have branches in Columbus, Cincinnati, and Cleveland area.
Okay.
So we cover the whole state of Ohio.
How about New Jersey?
There's
Yes,
we have two
Totowa?
two branches in New Jersey. Mhm.
Where else?
I thought it was just Totowa, but you know what, we actually have a website, it's CORAM.com, and
It's CORAMHC.com.
HC.com for healthcare, yes,
Yeah.
sorry.
And you can see the interactive map that we put up there.
Hopefully another question.
Is there a typical course of treatment that we give, or is it really specific depending on the child and their symptoms? I don't know much about IVIG.
Sure, I would say that we see maybe every 3 months. It depends. Every child is different, and what the prescriber chooses.
Usually, what I've seen is they see if your child responds, and then usually I think there's like a waiting period. And so if your child's a responder to it, you're more likely gonna probably need it again.
Actually, I would disagree with that. I don't know if the clinicians here have anything to say.
I was just gonna say, maybe we should ask Dr.
Yeah.
Cunningham.
They might want to speak to that.
If the model is correct and everything we have shows that it is, it's an acute post-infectious autoimmune disorder, so one course of treatment and adequate prophylaxis should be enough. But as we heard from Dr. Chapman, I think that the PANS construct is so much bigger that we really have to figure out together what we're treating. And I will be calling on Tuesday when I get back to the office, the National Call Center, because the PANDAS registry shouldn't be operating independently of that. So I guess I would say if it's been a year since your last treatment and nothing new and different has happened, I would have a hard time envisioning how a second IVIG would be helpful at that point in time. And the general use of IVIG, I think of it as a rescue, recognizing that the risks in other situations can far outweigh the benefits.
Mhm.
When you need it.
Right, so I'm
it's amazing.
Yes.
Yeah, I'm speaking
Correct.
more what we see in home infusion, so not from a scientific background. I have seen it prescribed more than once, but
Yes, and I know there are a number of clinicians who
Yes.
use it fairly regularly.
yes.
Hopefully, those are only in children who they have a secondary or possibly
Primary immune
process
deficiency,
of
right.
an immune deficiency.
Yeah.
Correct.
So a classic PANDAS child doesn't have immunodeficiency,
Mhm.
and you're only using the IVIG to reset the immune system.
Mhm.
Because they also can have a little dust up and symptoms right after the IVIG for a month or so.
Mhm.
And when they settle down, they should be permitted to settle down over a long period of time and not overreact to little blips. Just injecting IVIG too soon.
Mhm.
Yeah, we had another question right here.
Yeah, just from a home infusion perspective, are there differences with respect to high dosage versus low dosage IVIG?
Just the amount of time that it takes to complete the infusion. So we follow manufacturer guidelines, and so if you have a high dose, it's going to take longer to infuse than if you're treating someone with a lower dose.
But I think other diagnoses is we see low dose. So if we're treating primary immune, that's a low dose, usually on a regular basis.
Right, and they tried low dose versus high dose in Kawasaki's, in Guillain-Barré, and found that the low dose infusions don't work. And in fact, there was one study in Guillain-Barré that actually made things worse. So it's really important that I'm glad CORAM provides some sort of quality control as well for the application of these infusions to make sure that you're treating that individual patient's needs.
Thank you.
I just wanted to say that I think the whole issue of whether it's post-infectious or resistant infection or recurrent infection is probably a more gray area than otherwise. It'd be nice if it was so simple that we were just getting the kids who are infected and then getting treated with this because of the post-infectious process. Many of these kids are repeatedly infected, so it becomes a little bit more difficult to characterize it in that way.
Well, that's why we're going to hear her talk about Lyme.
That's right. Yeah.
I mean, I can say for my own son, who's a classic PANS child, he did have a miraculous recovery from 2 high-dose IVIGs 6 weeks apart, and returned to 100%, but then was reinfected with another germ, the Lyme, sent him back again to a little PANS, whatever you want to call it, really badly
of fits with what I was saying, so we didn't hear why they were considering doing it again this summer. But the thing that was concerning was that I didn't hear that there had been a nice recovery and then a period of quiescence and a retreating a new set of symptoms. So that, as long as you have a good reason to give it, then it makes sense. But if it's just on a chronic course, then you better be able to document immunodeficiency or some other recognized cause.
And I think you also, and I'm not a physician, I'm especially medication, but you also need to be treating whatever is the trigger. Whether it's strep, mycoplasma, if you have a chronic, infection going, you can't symptoms eventually go away, in my experience, as a non-doctor.
And that you can be a doctor.
Yeah.
I want to say thank you to Heather and Susan.
Thank you.
Thank you. Very informative.